tend to overcall it than undercall it. At least that's what I've seen, because what you don't want to do is undercall it and the patient being undertreated. So because of those reasons, I think the staging is not that common. However, if you are looking at from an academic point of view, this is my understanding, and I'll ask Khalid Bhai and Mustafa to pitch in if I'm missing something. But there's a difference between the esophagus, gastric, and rectal. So if you're in that priority, EUS has got a role. So its role in the esophagus is good, and it is established. In the gastric area, it's plus minus, and you can argue either way. In the rectum, there is no role, okay? So moving from the esophageal role, so the main differences between T1, T2 versus T3 and T4 disease. And the reason for that is that in T1, T2, you can go upfront surgery, whereas in T3, T4, you can give neoadjuvant. The second role is between differentiation, whether people can do ESDs, removal of the tumor, or whether the patient needs surgery. And that can be differentiated between T1A and T1B. But again, we can't actually differentiate that with a normal echo endoscope. You need a mini probe. And I don't think any center in Pakistan has got a mini probe. Sir, correct me if I'm wrong. Do you have a mini probe? Or?
No, we don't have mini probe, but interestingly, there's a center we got the mini probe, but they've got just the mini probe.
Okay. Okay, so as far as I know, there's no functional center with a mini probe there. So, and obviously the lymph nodes, or if you see multiple lymph nodes, that can affect the operability. Now, moving on to the gastric, again, there's an east and west divide, as Khalid Bhai was saying, that nowadays ESD is the gold standard. So there's a school of thought that you go into the stomach. In the stomach, the difference from the esophagus is that the tumor, my understanding is that it is more aggressive. So you want to, as an oncologist, as a surgeon, as well as a physician, you want to push more towards over-treating in a sense. So in those particular cases, for T2, T3, T1, T2, or T3, T4 differentiation, you actually give everybody neoadjuvant. The main difference is, can you take it out endoscopically or not? If it is T1A, you have removed the tumor, you've cured the patient. If it's T1B, then actually the patient should end up having surgical resection. And because EUS is either because of its availability or because of its dependability is not very clear. So one way forward is that any patient that has T1 disease has an ESD. And if on histopathology it's T1A, then that's end of story. And if it's T1B, then that patient can go on to have a gastric resection. And endoscopic resection does not affect your surgical resection in any way. We heard that you were very active on Facebook a few hours ago. So, in rectum, there is no role, as far as I know, except for in patients that have an MRI contraindication, or if you want to pick up a sample. So we have actually done these slides, so I'll quickly go through that, the T1, T2 staging disease. So here, the muscularis propria, you can see if it is, up to T2 disease, it's touching, it's going just to it, and in T4 disease, it's going all the way through to the aorta. So those are just a few images we went through. I'll just quickly go through them because we've done this in the morning. Staging of, I'll move on to, so superficial tumors. So T1, as I said, T1 can be removed endoscopically, and T1A and T1B can't. So this is where the difference between the T1A and the T1B. You can see here there are two muscle layers. One is the muscularis mucosa, which is the thin muscle layer, and that also appears hyperechoic in the echo endoscope. And then you've got the muscularis propria, which is like the big brother of the muscle layer. So it's actually the top layer. If you can see in T1A, the lesion doesn't go through it, and in T1B, it goes through the muscularis mucosa. If it is T1B, you need to have after ESD, you need if it's in the gastric area, you need surgery. If it's T1A, you can just take it out.
So, T1
the second.
muscularis mucosa, that's when it's called invasive. आप देखते हैं ना पैर के ऊपर invasive, non-invasive. Invasive वो होता है जिसमें muscularis propria involved through the lymph node. So T1A actually, like when you call it T1, it is already involvement of the submucosa. So the difference between 1A and 1B is how much the submucosa is involved. So this, अपने अपने कहाँ से लिए ये diagram?
Okay, so my understanding was different actually, and I'm sure I'm wrong here, but the muscularis mucosa, my understanding was that T1A is in which it's up to the muscularis mucosa, and in T1B it goes into the submucosa.
No, I think it's there is when it is less than 500 microns of submucosa involved,
Okay,
that is T1A.
okay.
So anything more than 500 microns of submucosa is T1A.
Okay.
No, wait, wait, wait.
I'll probably from one of the EUS
Maybe
books,
yeah.
yeah. So mini probes, we don't have it, so there's no point in going through it in much in detail. But essentially, the higher the frequency, the more clarity you will see, but you won't see that deep. And the
How often do you use mini? We are only using for colon, like the submucosal lesions in the cecum or somewhere, which is especially sometimes there could be an initial lesion. I think I'm not a big fan of this. So it gives you a really so much high resolution that it's really hard to figure it out where those layers are.
too many layers there.
Yeah, too many. So अगर कोई हमारा बाजू मरोड़े तो हम यूज कर लेते हैं बेसिकली, ठीक है, like that's the only good way है.
Yes.
Just want to do it. No, seriously, अब वो जो है ना जान छोड़ के कुछ चीज के अगर appendectomy करवा दो, नहीं आप कर दें, like can we do it? Yes, we can do it. But what we're gonna say after this, before this is the same answer. Unless it's
दूसरे अपने अगले को कहने के लिए आया वही कर जो पहले किया था.
or unless it's really clearly a lipoma, and that makes a difference. But lipoma, you usually are able to tell and stop it. So
The similar thing as the EUS, that the cardiologist producer is a different
get you.
intravascular ultrasound. Is it the same, the mini probe, or is it a
No,
different?
no, no. Vascular ultrasound cardiology is the other ultrasound.
Yeah, that's totally
Like the echo, that's totally. That's pretty much same what we have.
But it's much thinner and much.
Intravascular, I don't know. I don't think it's the same one.
It's not the
No, no, that this would not go. This is like a good size. You need a 3.2 millimeter working channel to put this through. So this is not that. Very tiny. जैसे आप एंजियोप्लास्टी बलून जो होते हैं ना, वो सिर्फ 0.8 करते हैं. ठीक है, वो बहुत छोटे बलून होते हैं. इसी तरह उनका जो है ना separate.
one mode. They don't have the. If I'm not wrong, then they don't have the picture mode. The B mode, they use the waveform. Maybe I was cardiac or like because it's छोटा होता है.
That is possible. Yeah. They only use the waveform. अभी तो मैंने अब बोला भी नहीं है.
My God, we got you from US. As much as you do in your unit.
आपके आधे पेशेंट्स खाना खा
मुस्तफा का तो मुझे पता है. मुस्तफा का तो ठीक है, लेकिन खालिद आप आराम से दिन में 40-50 कर लेते
वसीम ने लंगर खोला हुआ है, हर दूसरा मरीज जो है ना खा के आया हुआ है.
उसमें से एक
सबको खिला रहा है.
इसमें से एक पेशेंट जिसको आज आपने किया, it's a very interesting one. She's a young girl who presented interior sickness somewhere, I can't remember her. And she presented with acute abdomen. The surgeon felt the abdomen, opened it up, took the appendix out, actually had pancreatitis. And she's only 19, 18. After years, 70. I mean, it's really such a shame on the pancreatitis surgery. She ended up having complications of that. What happened?
I'll just move on from the mini probe. So essentially, what we were discussing, the cost, its operability, and the fact that it's got a learning curve and it's not as useful because of the ESD being more accurate in checking for vascular invasion. So nodal involvement can be checked as well, and we were discussing the features that we suggest that it may be a malignant lymph node. So at least a 10 millimeter lymph node, discrete, round-shaped, sharp borders with absent central nodule, hypoechoic, area that suggests that it's a malignant lymph node. And there are some other features as well, such as the lymph node being nearer a lesion, the total number of lymph nodes, and if somebody has T3, T4 staging, then most likely the lymph nodes that you're seeing are malignant. So any of those features can be used to differentiate between a malignant versus a reactive lymph node. And elastography is a technology that is used as well, but as we discussed previously, tissue is the issue. It may give you an idea, it may give you a guesswork, but it is not accurate as such. You can't rely on it completely. But essentially, blue is hard and red is soft. So if you find something that is more blue, you can target your biopsies in that area. Again, in this particular picture, you can see two areas of lymph nodes. This lymph node as compared to this lymph node. So if you compare this one with this one, this is inflammatory because it's, it's giving a green color, whereas this is malignant because it's giving a blue color. So if this was in one patient, you would try to target the one that is blue in color.
Do you actually yourself or other, how often do you actually use elastomer?
I occasionally do use it. How useful? बायोप्सी के लिए कभी lymph node मिल गया तो उसमें अगर necrotic area देख रहे हैं और hard area को मिल जाए. But if you ask me what evidence do you have, how does it work or not, it's just a button there in front of me. I can press it. It's nice pictures, for the presentation, etc. So that is for good. But if you say to me, does it will it change your management completely? I probably not. I know what Khalid is.
We talk about not using it, what is doing anything. That's a very small asset, definitely have to use it. That's the limit of our.
This question, the reason why I asked the question was for everybody else.
How many get
We haven't gone back because the cost, the difference of cost between the ultrasound that has these kind of things versus the ultrasound machine that gives you what you really need for like 99% of your patients is a significant difference in the cost. So that's something that you need to keep in mind, and the utility or usefulness कितनी है उसके हिसाब से you spend that kind of money, उससे बेहतर है कि you spend a little bit more and get an extra scope.
To be honest, we got it, I think, for free because it's just a software upgrade. You just ask them when you negotiate, and they will get it to you.
दो चीजें जो है ना अमेरिका में काम नहीं करती, एक इलास्टोग्राफी और दूसरा कॉन्ट्रास्ट.
Good. We are very happy.
करते ही नहीं है काम, पता नहीं वो वहाँ पे हवाई डिफरेंट.
हम कोई चीज अमेरिकी फॉलो नहीं करते, लेकिन ये दो चीजें फॉलो करेंगे.
आप फॉलो नहीं करते, आप मानते हैं.
अच्छा,
हम जानते हैं कैसे फॉलो करवाना है.
ये तो बात सही है. इसमें हम आपसे आर्ग्यू नहीं करेंगे.
मान लो.
एक तो उस्ताद, हमारा तो अमेरिका वाला मामला ही नहीं, हम जवाब दे नहीं सकते ना. उस्ताद हम लोगों को सिखाया ही क्या.
So generally for the it's okay. It's okay. We're just waiting. Just let us know as soon as the patient is ready. We'll move. So just for the staging, obviously, like Dr. Ghyas mentioned, the CT is the core investigation. PET scan can be used. It can be used to upstage, and in GOJ junction tumors, you can use laparoscopy as well, which can find more metastases that are missed in other modalities. So EUS is usually not indicated to see for MET. So if somebody asks you to do an EUS to see for metastasis, it's not indicated. Okay, so moving on to the gastric staging, as I said, probably the best evidence is in the esophagus. In the stomach, it's a bit iffy, and in the bottom, there is none. So again, the T staging is the same as for esophagus. You can use it to check the depth of invasion of the gastric cancers. And with radial EUS, you can see in up to 60%, and is better in the mini probe patients. However, this phenomenon of early gastric cancers, which is a Japanese phenomena, that has got EUS into play a bit more. So essentially, an early gastric cancer is the one that is limited to the gastric mucosa or submucosa, regardless of the involvement of the regional lymph nodes. And they have a significant better prognosis as compared to the tumors that have spread. In Japan, they have introduced this screening program, and actually their pickup rate for early gastric cancer increased from 15 to 57%, which is a significant number. If you can imagine, these gastric tumors are usually deadly once they are spread. So it does, screening program does work. What about the role of EUS? So submucosal dissection is considered to be not only diagnostic but also therapeutic, and therefore it is a preferred way of managing these early gastric cancers. So if you see a spot, rather than doing EUS and assessing it, you can just have an ESD done. If it is an advanced, let's say 1B, you can then offer them resection. If it's just 1A, then you've done whatever needed to be done. So there's an east and west divide. In the West, in the UK, they still offer patients to have EUS. I'm sure in the US as well. Whereas in Japan, Korea, etc., they just go for ESDs. But Khalid Bhai was mentioning nowadays in the US also they just go straight for ESDs.
Based on cross-sectional imaging.
Yes, and endoscopic appearance of it as well. I mean, to be honest, I've not seen many early gastric cancers. I think because we don't have a screening program here. By the time they come, they are really advanced.
You don't have that kind of gastric cancer
Tumors, yeah.
because your
Huh.
incidence is not that
Not
much.
that much, huh.
Japan obviously is high. So I don't know. Although I see everybody coming to me from other colleagues sometimes with H. pylori positivity, and they are so scared of cancer because of positive H. pylori, and I think we're responsible for creating that misconception. I don't know. Our practice, we don't see that much gastric cancer as obviously the Japanese incidence.
Huh.
And we are selected groups. So आप यहाँ, your hospital or our hospital here, we have very skewed selected population coming for surgeries or procedures. But I think in this country itself, I feel what I just after
it is not all that common.
Do we have a ESD center for example, does your center do ESDs for this? Israel. Okay, so because we don't do it at the moment, so I think that is something as well. If we centralize it, if we send any early gastric.
I'm sure the problem we face is that the cases aren't enough. The
Huh,
cases are very
yeah.
rare. If you go to Japan, they are doing ESD after ESD because
Oh.
there are so many cases. Right?
Oh.
They're picking up early. Probably, obviously, we are not picking up that early, and there are many reasons for that. But I think it's the rarity of cases that is not allowing the field to spread
To
more. I
develop.
don't think ESD it's not that big an issue, especially if you want to do it in the rectum. I think that's the best place to start with.
Yeah.
That's probably the key.
Okay, so nodal involvement as well, like we discussed previously, there's a classification for it. Regional lymph nodes of the stomach, I wouldn't go through all of that, those anatomy. But there is limitations of EUS in assessing for nodal involvement. CT is better to check for it. And therefore, the role of EUS in gastric cancers is not as clear-cut as it was in the esophageal cancer. Metastases as well, as I discussed previously, there's not much role of EUS in mets. What about in rectal cancer? So again, you can check for the tumor invasion of the rectal wall, which is similar to the invasion in the esophagus and the gastric area. However, the studies have shown that if you compare MRI scan compared to the endoscopic rectal ultrasound, there's actually no difference in the T staging, and there's also not much different in the nodal staging. So then what's the point of doing a rectal ultrasound scan? So the role of MRIs of EUS only is in patients that have either a contraindication to MRI scan due to whatever reason, they are claustrophobic, or they've got some device in them, or you want to biopsy or sample a lesion or lymph node there. That may help you with the staging. And again, as with previously with metastases, EUS is not indicated. You can do some fancy stuff as well, fiducial placement, which are small little, gold beads. You can put it in that can help the radiologist or the, radiation oncologist to target it. Again, I, to be honest, have not had experience here. I'm not
We
sure.
have, the cyberknife.
Yes.
So
And have you used the pre-meds one, or have you guys decided
They
designed some?
actually arranged it for us.
Okay, so did they gave you a bead and
Yeah, so they gave us the
little pellet, yeah, and you put it through your normal 19 gauge needle and just put the stylet on top. Okay, okay, so that's. Um, so in summary, like we discussed previously, just to remember, I personally think the role of EUS in staging is limited. It is not something that everybody needs to do, because you need to do a certain number and you have to have a bit of a love for it to do it. I don't feel that I'm one of those persons, to be honest. But if you do have it, then the role in the esophageal is quite significant. In the stomach, it is very questionable, and in the rectum, it's minimal.
What do you think about, what do you think about